Welcome everyone to our CARE Act 202 training, where we will be providing some high-level information on the CARE agreement and CARE plan and talk about some of the similarities and differences between those. We know that there is some great work being done on the county level to help get ready to provide this support for residents of your county. And so this training, we hope to better equip you to do that. The goal of these trainings is to help you feel prepared as you begin to implement the CARE Act, and we want to be responsive. So of course, as always, please let us know if there's additional information, technical assistance that you need, and please make sure that you're signed up to receive notifications for trainings, which we could share. So on the next slide, we'll see some information about some of our presenters today. We have Rachel Johnson-Yates, Deborah Rose, Mark Avery, and Carol Clancy, some of our colleagues at Health Management Associates that have been combing through the CARE Act and thinking through how we can help this group implement the CARE Act. So on the next slide, we'll just take a brief look at the agenda before going over the learning objectives. So in the CARE Act 201 training, we introduced a high-level overview of the CARE Act process. So if you want an in-depth information about that process, you can go back and look at that, the recording of that training, or review the PowerPoint file for that, which you will see in PDF format. So in this training, we're going to review parts of the CARE Act process with an emphasis on those two inflection points of the CARE agreement and CARE plan, and then looking forward to the graduation plan. We'll compare those different requirements and then talk about voluntary engagement and how that fits into it. And we'll preview some of the outcomes of that 1 year review to be considered at the outset of the CARE Act process. The second half of the training will focus on some of the required components of the CARE agreement and CARE plan, and then talk about some strategies for engagement, coordination, and then individualized according to a potential CARE Act client or respondent. On the next slide, we'll look at some of the learning objectives that we're looking. Again, we hope to better that you will have an increased ability to implement the CARE Act and do some of these, identify the key points, describe the differences between voluntary engagement, CARE agreements, CARE plans, identify some of those elements of the CARE agreement and CARE plan, and then describe strategies for engaging the client and respondent in the CARE planning process. The goal isn't for you to feel like you can do this on your own, and you don't have to. You have the counties around you, the technical assistance is needed. So please flag those needs for us as they arise. So with that introduction, I'm going to turn the time over to Carol Clancy to do that review of the CARE Act process and where the CARE agreement and CARE plan come into play. Carol?
Thank you, Patricia. In this section, we are going to review the CARE Act flow. So next slide. So the CARE Act is about leveraging a system to help provide support, but we never want to lose focus on helping an individual. So we're going to look at this process through the lens of a respondent, Maria. Maria is not just one person. She's a conglomeration of people that many of us have worked with before. And as we go through the content today, keep in mind that Maria's background and her current situation and what her experience would look like in creating a CARE agreement and CARE plan. So let's look at what Maria's background is. Maria is 40 years old. Spanish is her first language. She was diagnosed with schizophrenia at the age of 24. She has a history of drug use, primarily heroin and opiates. She is diabetic, but she does not manage her diabetes well. She has parents who are her primary support network. However, they are unable to house her due to her symptoms. And so she often ends up living in abandoned buildings around the city and sometimes will stay in shelters. Her current situation is she's intermittently engaged with mental health and SUD services. However, she has not been engaged with them for the last 4 years. She does not seek care for her diabetes. So when her diabetes gets out of control, she just ends up in the ER. Recently, she has had incidents where she's become verbally abusive to community members, and this is due to her psychosis. In the last year, she's been arrested 3 times. Each time she spends less than 30 days in jail before she's released. And she stays in abandoned buildings and shelters, and she has been assaulted several times recently when she was in shelters. Next slide. We want to start off by showing the high-level process overview. Now, in today's session, we're going to talk about a few key inflection points involving a care agreement and care plan, and we also are going to talk about voluntary engagement. We're going to be talking also about the graduation plan. We always want to start this whole process with that graduation plan in mind. So we'll be covering this middle section here under this red bar of the court process, and then this last yellow bar here. Next slide, please. So this, again, this is that middle section where we'll be talking about. So first, we'll talk about the care agreement at the hearing on the merits. If the court finds that Maria is eligible for care, the court will order Maria, her attorney, the behavioral health agency, her identified volunteer supporter, if Maria has one, to attempt to develop a care agreement. And we'll go into the components of that plan later in this training. The care agreement will be reviewed in the case management hearing. If a care agreement was reached, they will work together to formalize that in court. If the care agreement wasn't reached, the behavioral health agency will complete a clinical evaluation and write a report along with recommendations for services. Next slide, please. So whether it's a care agreement or a care plan, it will be this group here that is working together. The client, in this case, Maria, her attorney, the behavioral health agency, and the volunteer supporter. Remember that the volunteer supporter there's only a volunteer supporter if that is what Maria chooses to have. So if she does not desire having a volunteer supporter, it would be these 3 people, her attorney and behavioral health agency, that are working on the care agreement or care plan. Next slide, please. Now, in the next few slides, we'll be going over each of these, but we wanted to show a side-by-side comparison of voluntary engagement, the care agreement, and the care plan. So the first one, the voluntary engagement, would happen early in the process once there is a prima facie and a county agency has been ordered to assess the client. If services are accepted, then the case is then dismissed and no care agreement or plan are needed. However, since this is a process, Maria might initially say, no, I'm not interested in that. And so she doesn't initially agree to services, but the behavioral health agency may find her to still be eligible. So what they'll do is they'll attempt to create a care agreement. The client, Maria, is able to accept or deny services in the agreement, but if accepted, the care agreement is developed and approved by the court. If the care agreement is not voluntarily agreed to by Maria, then a clinical evaluation is ordered. If the client, Maria, is still found eligible for services, at that point, the care plan is developed under a court order. Next slide, please. So once there's a prima fascia showing, the county behavioral health will attempt to engage Maria in services. If Maria voluntarily accepts, the behavioral health report indicated voluntary engagement is submitted and the case is closed with no further action needed. Next slide, please. Now, in a care agreement, the difference between the care agreement, in both a care agreement and a care plan, they will include specific services that Maria agrees to. The difference between the care agreement and the care plan is that the care agreement may include court oversight, but the care plan always includes court oversight. Next slide, please. So a care plan is developed if the client still refuses services and a care agreement is not approved. The court will order at that point a clinical evaluation to assess eligibility. The client may have a volunteer supporter again during this process. And if Maria is found eligible, a care plan is created and presented at court during a care plan review hearing. During that hearing, the court will decide on which elements will be included in the care plan to support Maria's recovery. Next slide. So there is another difference between the care agreement and the care plan, and that is what happens after each of them are developed. So if Maria enters a care agreement, there will be one progress review hearing. Counties have the option to continue to have progress review hearings, but by statute, they do not have to have them. If Maria enters a care plan, there's a status review hearing, and then the statute requires review hearings at least every 60 days. Next slide, please. So now we come to the graduation hearing. If the care plan was entered into at month 11, there's a 1-year status review hearing with the goal of determining the next step. So we'll review what those options are, including graduation or reappointment. Next slide, please. So this is an overview of what happens at the 1-year status review. There's 3 potential outcomes. The first outcome is that Maria elects graduation. This means that Maria is doing well. She'll work together with County Behavioral Health to develop a graduation plan, including the services that she will continue to engage in. The second option is that Maria voluntarily elects to stay in care. So if she requests this, the court may permit her extension for up to 1 year. So she may want to do that for if she feels like she has better accesses to services or because of the accountability. And this is not something that we are expecting will happen very often. Usually it would either be Maria would voluntarily graduate or there'd be an involuntary reappointment. And an involuntary continuation would happen maybe if Maria had just started to engage toward the end of the year. So it appears that it would benefit for her to stay with the care plan. And this reappointment would only happen for up to 1 year. Next slide, please. So if Maria elects to be graduated from the program, the court will order the County Behavioral Health Agency and Maria to work jointly on a graduation plan. The graduation plan is going to include the same elements as the care plan to support Maria in accessing community-based services and supports. The court will schedule that hearing in the 12th month after the adoption of the care plan for presentation of the graduation plan. Upon completion of that hearing, the respondent is officially graduated from the program. The plan may include a psychiatric advance directive, which is a legal document executed on a voluntary basis by a person who has a capacity to make medical decisions. So it would allow a person with mental illness, in this case Maria, to protect her autonomy and her ability to self-direct care by documenting her preferences for treatment in advance of a mental health crisis. An advance directive does not place more responsibility on a government agent entity, because this is not enforceable by the court. Next slide. So the next option we'll just talk about in more detail is the reappointment. So let's say Maria feels like it has really been beneficial for her to be on the plan and that she would be able to get more benefit from it. So at that point, she can request a reappointment, which is up to 1 year. Or she can be, again, involuntarily reappointed to the program if the court finds by clear and convincing evidence that all of the following apply. So that Maria did not successfully complete the care process, that all the service and supports required through the care process were provided to her, that Maria would benefit from continuation in the care process, that she continues to meet the requirements for care, so all those requirements in section 5972. And she can only be reappointed once for up to 1 additional year. Next slide, please. So now what we'd like you to do is just take a few seconds to just write down 2 or 3 differences between the care agreement and the care plan, and to think about what your continued questions are for that, so that you would be able to speak with other people in your county, or ask for technical assistance on some of those differences. Next slide, please. So now I'm going to hand this over to Deborah.
Thank you, Carol. Next slide, please. I'm going to talk a little bit about what's in a care plan. And to start, I would like to make clear that when we're talking about behavioral health services, that behavioral health includes mental health services, substance use disorder services. So we're using the term behavioral health, mental illness with co-occurring substance abuse interchangeably here. Medically stabilizing services, medically stabilizing medications is the specific language in the statute. And I'm going to let my colleague talk about that in the next slide, but that can include an array of services that Maria may benefit from, and he'll get into more details on that. Funding for housing resources. This can be a range of housing resources. This could be supportive housing, as is written into the statute. Bridger housing is prioritized. Bridger housing is really designed to provide intensive wraparound skill building, residential and housing services to help people learn to live independently or with supports in the community, and to become connected to wellness and recovery services. And additionally, funded social service programs, which may be things like applications for benefits, SSI, entitlements, food or nutritional services. A couple of important notes that I would like to bring to your attention is that these are all designed in conjunction with each other as part of an entire comprehensive package of wraparound services to help somebody on their journey towards recovery and wellness in the community. What matters here is that it's not only about the recipient, it's not just about Maria and what she can be provided, but also what she has the right to be provided. And so this plan is designed to support her individual needs, her preferences, her cultural and linguistic preferences, and it holds the county accountable to provide those services to Maria. So it's both designed for her, but also as a in responsibility to her. The judge can really order whatever is included on this and can prioritize certain services, namely bridge housing. We're continuing to learn more about what that means to prioritize services, and we do understand that there are questions that are coming out. We hope to be able to give some more definitive answers and to support that understanding. Services are, of course, tied to available funding and resources for those services. And one other distinction is that these specific areas or what's listed, what can be listed on the care agreement, but there are other services that can be provided in addition to these listed court-ordered services, and that other service can be suggested by the court as well. We've heard from the counties a request to try to create a uniform template for a care plan. And we've been receiving some information and we're working together to try to create a form that can be used or modified across the state to develop and implement both a care plan and a care agreement. Next slide, please. So as I mentioned, behavioral health, and again, behavioral health services for the folks living with mental illness or substance use disorder can include a range of things. Mainly, and perhaps most effectively, are evidence-based services like the Full Service Partnership, FSP, or Assertive Community Treatment Act, other kinds of intensive outreach services that are designed to meet a recipient wherever he or she is. If Maria is living on the street, the services can be provided at the street corner, in a restaurant, in another setting of her choice, really intended to be engaging, comprehensive, and hopefully bring somebody into care. And case management is certainly one of the significant components of behavioral health services, which could be included in the plan. Other things that can be included are more traditional services that we think of, like an outpatient clinic, substance use services, day treatment programs. One service which is extremely effective are peer support specialist services. And peers are really folks who have lived experience, personal experience of substance use, of mental illness, of having lived through that recovery journey. And peers can provide coaching, mentorship. Often peers are the ones who are really able to inspire hope and engage with folks in ways that traditional providers and practitioners haven't been able to do. So peer services is a fantastic approach to engaging recipients in this recovery model. Community health workers can be included, and these may be folks who can offer some skill building, some connection to primary care, to preventive services, to other specialty services, especially for recipients who are living with co-occurring medical conditions that can be challenging to serve in the community. And then social determinants of health or health-related social needs, depending on who you're asking, what term we're using. And these can include, as I mentioned earlier, things like benefits and entitlement applications. Perhaps Maria would benefit from benefits, could be assisted to apply for Medicaid or SSI or SSP. So it include things like that, transportation, medical transportation, and non-medical transportation, to appointments, to the court, to visits, to the voluntary supporter, to obtaining a cell phone or making appointments in the community. So really, again, the agreement, the plan is designed to provide comprehensive wraparound range of services that can support somebody in the community to living with more wellness and recovery. I'm going to turn this over to my colleague, Mark, who's going to talk a little bit more about medications.
Thank you, Deborah. This is Dr. Mark Avery. With this slide, I will discuss circumstances around the inclusion of medically necessary stabilizing medications in a CARE Act care plan. As we've previously stated, the court may order that medically necessary stabilizing medications be included as one of the 4 types of services in a CARE Act care plan. But this can be included only if there is clear and convincing evidence that the respondent lacks the capacity to give informed consent. Note that this is a fairly stringent standard to meet, and there are numerous situations where a person may not take their medications but still not meet this standard. The ability to give informed consent generally requires a person's basic understanding of their condition, the reasons for the proposed treatment, understanding of treatment alternatives, and understanding the right to refuse treatment. Also note that though the clinician documents whether a patient appears to be able to consent or not, it's really up to the judge to rule if the respondent lacks this capacity. So let's imagine that our client example, Maria, clearly needs antipsychotic medication for her condition, but she does not herself grasp that she even has a mental illness, nor how medications might even be useful. In this case, Maria likely does not have the capacity to give informed consent, and thus stabilization medications may be added to the CARE Act care plan for the judge to make a ruling. Also note that the terms medically necessary and stabilizing medications are both legally defined. The term medically necessary refers to when a medication is reasonable and necessary to preserve life, prevent illness, or alleviate symptoms. But the term stabilization medications or stabilizing medications is defined in the CARE Act itself and includes clarification that they consist primarily, though not exclusively, of antipsychotic medications. So for instance, again, let's consider our patient example, Maria needs both an antipsychotic medication and a mood stabilizer to adequately treat her schizoaffective disorder to prevent serious deterioration in her condition. In this case, both medications could be entered into the CARE Act care plan. And finally, note that though the CARE Act care plan may order medications, it does not empower the forcible administration of medications at any time. And with that, I'd like to pass the mic to Rachel Johnson-Yates to discuss some additional care plan topics.
Next, we're going to talk about housing resources, supports, and other social services. So starting with housing may include a myriad of options, including permanent supportive housing, interim housing models like the bridge model, affordable housing models, community-based housing. And if you look in the statute in section 5982, you will see a myriad of housing resources that are mentioned there. So as we're thinking about these housing resources, it really is important to remember that the BH Bridge Housing Program includes prioritization for the care respondents. And so as we're talking about housing today, I would really like to encourage anyone that is available to attend our housing trainings upcoming in June that will have a lot more information about the housing resources, funding, and the access to housing as we are continuing to roll out the CARE Act. Next slide, please. So I would love everyone to take a moment and just think about the last time that you felt like a number. And so this may have occurred in a space where perhaps you were at a doctor's office or a restaurant or a grocery store. And think about when you were really trying to communicate something that was important to you, but you just weren't feeling heard. It's really, really important to remember that our clients have had a multitude of experiences within various social service settings, and they will have a lot of valuable insight into what has worked for them, where they may not be interested in going, what sorts of services have really benefited them. And it's really important that we take the time to ask these questions, to individualize the care plan to the person and the human being that is in front of us, so that we are intentionally making sure to meet the whole person needs of the client. The care plan is going to include things like housing, mental health support, substance use disorder needs, peer supports, and a myriad of other community supports. For the client, it is really important to help talk with them about what are priorities in terms of their perspective. What are their biggest needs? Which things have the largest amount of urgency? Where can we offer short-term wins to help generate buy-in? All of these things come into play as we're trying to think about how might we best serve the individual in front of us in a way that is tailored to them as a whole, unique human being. Next slide, please. So let's go back to Maria for a minute. In terms of Maria, individualization means she prefers not to meet in a clinic because of her mental health concerns. Being in enclosed spaces or crowded spaces feels really, really anxiety provoking. And so it's really important that she has a space to meet that feels like her baseline isn't going to be trauma activated and on a high level of anxiety. She has a co-occurring opioid use disorder that absolutely has to be treated in terms of being able to manage the mental health symptoms that she's having. She prefers individual sessions rather than group settings because her anxiety peaks when she's in crowded spaces. So she prefers to ensure that she has that kind of one-on-one time with a provider or providers. Maria is not English proficient, and she prefers Spanish-speaking communication. It is really important that we work with her to find a provider that is able to offer services in the language of her preference so that we're able to make the biggest impact possible. Maria has some religiously oriented trauma that has happened in her life. And so she feels very, very passionately that she would prefer a treatment program that does not have a religiously oriented approach. And in terms of her medication, it's really important for Maria that she has a say in terms of which medication that she has tried, that the doctor or the prescriber that she's working with is responsive to those needs, and that they are willing to hear her history with the various medications that have not been a fit for her and consider options that may be a better fit moving forward. Next slide, please. So let's talk about individual engagement needs. Being mandated to anything can feel very, very overwhelming. Imagine the experience of being mandated to treatment. It can feel like your autonomy has been lost, like your independence is at risk. And for, I think, any person, this can be a very scary process to engage in. And so it is important that we keep that in front of mind as we're talking to the clients that we're serving. We are responsible to frame the CARE Act as a potential opportunity for our client to be connected with resources that may help them solve problems that they've had for months or even for years. The framing of the resources, the connectivity, the way that we might be able to partner with other agencies to help our client meet the goals that they have is really, really critical. In order to fully meet the client's needs, we're going to have to take a multifaceted approach. So it's going to take expert outreach and engagement. And this means the traditional methods of outreach and engagement may not work. We may have to do a little extra footwork to connect with the client, to reach out to them, to help work toward engagement. Motivational enhancement is going to be the name of the game here. So for clients that we are working with that maybe are resistant to engaging in the CARE Act process, maybe are experiencing some anxiety, some hesitation, anything that we can do to slow down, to be present, to help talk through the concerns that they have, to offer choice when we're able to, is going to be really, really helpful in helping enhance that person's motivation to engage in treatment rather than contributing to or exacerbating the anxiety that they may have. It's really important that we prioritize client choice where we are able to. And so this means where it may look like at first glance, there aren't a lot of options available, right? If a person is being court mandated to treatment, it may feel like they have lost their autonomy. When the truth of the matter is that if the client is engaging in the CARE Act process, the intent is for this process to be done in collaboration with the client and prioritizing their preferences and choice in every possible way that we can. Additionally, it is really, really important that every single aspect of how we approach the care plan development is done in a culturally and linguistically appropriate and accessible manner, meaning we are considering the whole person and all of the intersections of their identity, whether it be their race, their gender identity, their mental health concerns, their any sort of disabilities that they may have, language, any number of things, sexual orientation. will all contribute in a different way for each individual to what sorts of treatment settings and modalities will feel like a fit for them. The other thing that is really tricky about navigating the care plan process is we have a lot of stakeholders that have to come together for the best interests of the client in front of us. So we, of course, have the client respondent themselves, who are really our primary focus. We have the volunteer supporter, who may be a friend, family member, loved ones, other support person for the client. We have the courts. We have all of the providers that may be involved. And our role is to ensure that there is coordination, that there is engagement, and there is information exchange. For the CARE Act to work to really, truly provide a foundation of support, and for the client to be able to lean on this foundation to reach their own defined goals and the goals that will help keep them safe and stable and functional within society, it means that we have to be talking to each other. We have to be engaging with each other. We have to make sure that we are intentionally creating checkpoints for information exchange, and that we are working as a whole lockstep unit to wrap around this client and ensure that they are getting the care and the support that they need. Next slide, please. So we've talked a lot about Maria's unique needs. And if you would, considering everything that we've talked about today, take 30 seconds and just write down or jot down somewhere what sorts of things might be a good fit for Maria's care plan. And take into consideration your locality, the resources that are available in your community, and decide what sorts of things might you offer to Maria as a menu of choices to help promote her choice, to individualize the care that she's getting, and to offer options that we feel like, based on the preferences that she's given us, may be a good fit. And with that, I will pass it back to Patricia.
Thank you, Rachel, and thank you, Mark and Deborah and Carol as well. Just as a reminder, we hope that by the end of this session, you had an increased ability to identify those key points in the CARE Act process, where the care agreement, care plan, and graduation plan come into play, and then understand and describe some of the similarities and differences with voluntary engagement, care agreements, and care plans, and then identify some of those elements of the care plan that Rachel, Mark, Deborah were just going over, and how those could be operationalized in your county. And then describe some of those strategies that Rachel was reviewing about how we take those skills that you already have to individualize and engage clients and respondents, and think about how that could apply to the specific use case of the care planning process. If we can go to the next slide, highlight some next steps. Please continue to visit the CARE Act website for resources, including recordings of trainings. And also you can submit those questions and technical assistance requests. And please, if you'd like to receive that trainings, notifications for trainings, TA, or other engagement opportunities, make sure you're joining our communication listserv. So with that, we'll flash to the next slide. We see the CARE Act website and our CARE Act email address where you can submit any requests. Appreciate your time, and please let us know if there's more support that we can provide. Thank you so much.